Hello everyone, and welcome to the webinar, Meeting the Health Center's Mission and Margin, Making the Business Case for Integrated Community Health Outreach Programs. My name is Molly Meinbreth, and I will be the moderator for today's webinar, which is a production of the National Healthcare for the Homeless Council, with support from the Health Resources and Services Administration Office of Special Population Health. This session is being recorded and will be archived in 3 business days. This is a 1-hour presentation with the last 10 minutes reserved for questions and answers. Below the presentation slide on your screen, there's a chat box for participant questions and technical issues. If you're experiencing an urgent technical issue, please call Patrina at 615-226-2292 for immediate assistance. Please type your questions for our presenter into the chat box at any time during the webinar. A selected number of questions will be answered at the end of the presentation during the Q&A session. Thank you for participating in this webinar. Today's session is the second in a series of webinars designed to help healthcare for the homeless grantees assess the cost benefits of their services. Last week we heard about a costing tool from researchers at Brandeis University that can be used to evaluate a multitude of health center programs. That webinar is now archived and can be accessed on our website. Today, we're going to hear about a framework and toolkit developed by our colleagues at Health Outreach Partners to assist health center administrators in determining the business value of specifically integrated community health outreach programs. Kristen Stoimanov will be our presenter today. Kristen is Deputy Director at Health Outreach Partners, or HOP, where she oversees all training and technical assistance services for community health organizations across the country serving vulnerable and underserved populations. She joined HOP as a project manager in July 2004, providing program evaluation, program consultation, and training to health outreach programs. From October 2005 through 2010, she managed specific aspects of HOP services in her role as program director. Prior to joining HOP, Kristen worked as a grant writer for La Clínica del Pueblo, Incorporated, a community health center in Washington, D.C. From 1998 to 2000, Kristen served as a Peace Corps volunteer focusing on community health in rural Guatemala. She holds a Master of Public Health with a focus on health behavior and health education from the University of North Carolina at Chapel Hill. Her public health experience includes skills in program development, implementation, evaluation, community organizing and community development, and health promotion and education. We're really excited to have Kristen speaking with us today, so I'll go ahead and hand the microphone over to her to begin the presentation.
Thank you so much, Molly. Thank you for the nice introduction. You heard a lot about me. I'll tell you just a little bit about Health Outreach Partners. We're one of the national cooperative agreements like the National Healthcare for the Homeless Council, and we focus on helping health centers build strong, sustainable community health outreach programs. So our training and technical assistance services are available to health center program grantees. So keep that in mind if you think of things that you are interested in talking with us about after the webinar. Today I'm going to introduce to you HOP's Outreach Business Value Model and Toolkit, and by the end of the webinar I'm hoping that you'll be able to identify at least one financial benefit of outreach that you think would be relevant to your own health center and your own programs. I'm hoping that you will understand how to be able to apply our strategic framework in order to structure relevant outreach services in your own programs. And finally, that you'll be able to use the toolkit, and I'll show you how to access it, to really go through the process of assessing the financial implications of investing in specific outreach activities that make sense for your programs. It's important to start with a definition of outreach. There are lots of definitions out there. Some are very narrow. Ours is very broad, and you'll notice that it includes a lot of what we traditionally think about and talk about as enabling services. But we've been supporting health centers to do good community outreach since 1970, and so we really see this as an ongoing process of improving people's quality of life. And it includes facilitating access to health and social services, providing direct health education, bringing linguistically and culturally appropriate responsive health care directly to the community, which the Healthcare for the Homeless programs do so incredibly well. Helping people become equal partners in their own health care, and finally increasing the broader community's awareness of the presence of underserved populations. So there's an advocacy piece in our definition of outreach as well. Lots of different types of staff do this work. I know in the Healthcare for the Homeless programs, many physicians, nurses, nurse practitioners, physician assistants are providing direct clinical services in the field. We often talk about it as in an outreach setting. But there are lots of other types of staff who do outreach. They may be called outreach workers, community health workers, promotoras or promotores de salud, social workers, health educators, care coordinators. Those folks can do outreach too. Some do it as a small part of their job, some do it frequently. But there are lots of different types of staff who can provide services in an outreach setting. So what we're really looking at broadly here is how can outreach, how can you best serve the people in your communities and in your programs that are best served outside of the health center walls? Providing clinical services, as most of your programs do, absolutely. But what other supportive services can be provided to give your folks the best care they can get, and how can you make it cost effective? That's what we're going to talk about today. As I mentioned, we've been supporting health centers to do outreach since 1970, and it's always been very easy to make the mission case for the kind of outreach that I just described. Migrant health programs, Healthcare for the Homeless programs, you all know especially that outreach is a critical way of reaching the most vulnerable members of our communities. But when budgets are tight, it can be a little bit harder to make the business case for outreach. A lot of the services that we talk about when we talk about outreach are not directly reimbursable or aren't fully covered even when they're included in a wraparound rate. The impact of outreach on health center revenues isn't well documented or understood, so these programs and these initiatives become really susceptible to limited funding and budget cuts. So we want to develop something that would help health center decision makers, the CEOs and the COOs who are holding the purse strings and having to make important, difficult decisions. We want to develop something that would help them quantify the potential financial impact of an integrated health outreach program. And I'm going to be talking to you about what I mean by an integrated health outreach program. So we developed a strategic framework, which I'm going to show you, and a corresponding toolkit, which I'm going to tell you about how to access, that can be used to help make that business case for doing outreach. We worked closely with John Snow Inc. to develop these tools, and they were informed by a number of background research pieces. We did a thorough analysis of peer-reviewed and gray literature, reports, monographs, but also peer-reviewed literature. We held a stakeholder forum in California of health center leaders in that state, and then we did key informant telephone interviews across the country with health center decision makers from 18 states in health centers that served multiple types of populations, and we surveyed people both in states that had expanded Medicaid as well as states that had not. Ultimately, we wanted to enable health center leaders to consider different pathways to potential financial benefits to help them assess the business case, as I said, of investing in certain types of outreach programs, outreach efforts. We do realize that every health center operates in a unique environment. Policy environments, payment arrangements, program structures, priorities, community needs, all of that stuff varies. So as a result, not every piece of this framework is going to apply to every program. So you really want to think about, as you listen and look through these things, what do you think would really make the best sense for your programs and your communities? The strategic framework is set up like a logic model, and I'm going to actually ask Molly to pull up a document that will show you the setup of the strategic framework, and I'm going to walk you through this in hopefully a little prettier, more interesting way. Wonderful. Thanks, Molly. So let me zoom this screen a little bit for you. And I would suggest that you all put your screen on full screen. You'll be able to see this a little bit more easily. So this is what the strategic framework looks like. As I said, it's set up sort of like a logic model, very much like a logic model. And there are 5 core components. The first column on the left, you'll see inputs or costs, and that talks about the resources needed for an integrated community health outreach program and the related costs. Then there are outreach activities, and I'm going to go through a series of different outreach activities. But again, every program is different, every community is different. You have to decide for yourself how you want to define outreach and which activities you think make the most sense for your programs. The outputs are the potential results of the activities that you engage in. And then in the very middle of the screen, you have that potential financial benefits section. And this shows the ways that certain resources and activities might produce a financial benefit to the health center. And finally, key internal and external factors to consider. So these are questions that will help you determine whether certain financial benefits make sense to pursue for your program. In the very last column, you can barely see it right now, but you'll see it a little later. These are 4 calculators that correspond to the potential financial benefits, and I'll talk you through what those calculators do and how you can get access to the entering your data in these calculators and getting customized results for your programs. Okay, so I keep promising to tell you what an integrated health outreach program actually looks like. So now I will do that. In some health centers, outreach workers, and by outreach workers I'm talking about the community health worker folks, the outreach staff, the promotores, not necessarily the clinical staff who do so much in an outreach setting in healthcare for the homeless programs. But in some health centers, these outreach workers feel completely isolated from the overall health center functions. In other programs, they're acknowledged at the very highest levels of the organization as a critical part of the team. In those types of programs, their role is included in formal ways across the health center systems, and this is what we refer to as a really high level of organizational integration. And the most highly integrated health outreach programs have the best potential to have a strong impact on outreach program effectiveness. We also found when we started putting together this strategic framework and looking at the most effective and cost-beneficial programs that the more fully integrated the outreach programs were, the more likely they were to see the financial benefits of outreach. So this is an important point. We're not just talking about one outreach activity in isolation having a potentially desired financial benefit. We're looking at a whole program that's integrated closely with the health center administrative and clinical goals and priorities and what potential effects an outreach program like that can have. So there's 6 different dimensions of integration. You can see it on your screen here. The 6 dimensions are along the left-hand side. So alignment of goals, leadership, communication, infrastructure, evaluation, and financial integration. And I'll talk briefly about what each of these speaks to. Alignment of goals really means that the goals of the outreach program flow from the overall clinical and business goals of the health center. Often, outreach programs that are really well integrated will develop goals and objectives that are linked directly to the goals and objectives in the health center's healthcare plan and or in the health center's business plan. So there's a clear line between what the health center has committed to its board, to its community, to its funders, and what the outreach program does to help meet those commitments. And then you'll see what different examples of a not very integrated program to a moderately integrated program to a fully integrated program can look like in the second, third, and fourth columns. The second dimension of integration is leadership. And this really speaks to the importance of having health center leadership include outreach priorities in their overall decision making. So this is often operationalized in health centers by having an outreach program director serve as a key member of the management team. So that voice is always in key leadership decision-making processes. The third dimension is communication. And this is important because really in too many programs, outreach is almost in its own silo, and the staff don't have a clear sense of how their work can directly support organizational initiatives or patient-level initiatives and activities. So communication is key. Communication between outreach staff and clinical staff, communication between outreach staff and administrative staff in order to avoid this sense of isolation. And also in order to avoid the sense that folks in the health center may not really know what's going on with the outreach program. We see this work both ways. Outreach programs may feel like their work isn't really valued or understood, but clinical and administrative staff sometimes feel like they don't really understand what outreach folks are doing if they're out in the community all the time. The fourth dimension of integration is having a well-developed outreach infrastructure. This is really important for truly professionalizing an outreach program. So it includes things like having an outreach program plan, having concrete tracking tools to show how and where outreach staff are spending their time, and making sure that there are clear job descriptions and protocols in place so that the outreach team is set up to be as effective as possible. We've worked with many programs that really rely on institutional knowledge and long-term connections that have been built by staff have been around for years. And these people become very important to these health centers, but when they leave, if they retire or relocate or find new work, then the program can seriously flounder. So building that infrastructure in is important. Evaluation is the fifth dimension of integration. It's a key component of any effective program, and outreach is no different. You need to know what you're trying to achieve and understand if the important efforts you're putting into it are actually achieving your desired results. One example might be health fairs. And we've worked with lots of programs, lots of health centers that have outreach programs who focus a lot of their energy on coordinating, participating, implementing health fairs all over the community. But when evaluating the results of those health fairs, have sometimes come to find that they're not really yielding the increased access they were hoping for, the increased number of patients coming in they were hoping for, certainly not the improved health outcomes that they would ultimately like to strive for. So through evaluation, some of the health center programs we've worked with have maintained some level of health fairs in the community for visibility, but pulled back and made sure to make space for other activities as well. The final dimension of outreach program integration is financial integration. Many outreach budgets are cobbled together through fragmented, often disease-specific grants. So you might have a diabetes education grant, a smoking cessation grant, a breast and cervical cancer awareness grant. These might all have different staff. They might only be available for a year, and then they go away, and all this continuity is lost. So ultimately, we're advocating for investing in outreach for the long term, fully integrating it into the cost of the health center operating budget in order to improve the likelihood that the long-term financial benefits can be fully realized and the benefits to your patient population can be fully realized. Again, this is our ultimate desired integration, the outreach program being fully integrated into the health center operating budget. But it's challenging, of course, because not all outreach activities are reimbursable, as I mentioned, or fully covered when they are put into a wraparound rate. All right, so let's look back at the strategic framework. So we're going to start digging a little deeper in here. Remember, there are 5 key areas of the strategic framework: inputs, activities, outputs, potential financial benefits, and key internal and external factors. So looking at inputs, one moment. Excuse me. So the resources required for your outreach efforts and the related costs. Personnel, obviously, all the costs related to staff conducting outreach, salaries and wages, fringe benefits, but you also want to take into account things like staff turnover, recruitment costs. All of those things go into personnel, training costs. Transportation is often an input, is often a cost, a resource that goes into an outreach program. It can include buying vehicles, maintaining vehicle insurance, owning or leasing arrangements, buying taxi or transit vouchers for patient transport, and liability insurance is a really big one that we hear about all the time. Supplies are an important input, and it depends on what your program is doing, but it could include medical equipment like diabetes screening equipment or blood pressure check equipment. Lots of programs send their folks out with tablets in the field for collecting patient data. Software, print material, all of those things go into supplies. Overhead includes those costs that go into the ongoing expenses of operating a program. Rent would be included in that, utilities, phone costs, and other non-direct costs. If you're doing a lot of outreach and you're bringing in new patients, you really should include in your inputs, in your resources, the incremental cost of caring for new patients. So are you going to have to spend more money to provide more clinical care to more patients? To expand capacity in your health center if you need to add space. This is incremental cost of care. And then along the bottom column, you see outreach leadership and management. These are the dimensions of integration, and they fall into the rest of the framework in an important way. So you have to account for and pay for leadership and management to oversee all of these efforts, and that should be considered an input. All right, going back out, we're going to move to outreach activities. And remember, it depends on your program. It depends on your community. You need to define it for you. I read recently a very wonderful report that was developed by the National Healthcare for the Homeless Council and the National Consumer Advisory Board, entitled Exploring Enabling Services as Bridges to Care. And this report compiled the results from interviews with 321 currently homeless patients. And they analyzed the enabling services that are currently provided, that are most important, and that are most requested. And some really interesting things came out of that. Consumers told the surveyors that food and clothing and shower facilities were the most commonly available enabling services. And some of these enabling services are stipulated in the HRSA definitions, what you would report in your uniform data system. Some are additional services that are provided by Healthcare for the Homeless programs to really meet the full needs of their population. So those interviewed said that food, clothing, and shower facilities were the most commonly available. And when they were asked what the most important enabling services resources were, they mentioned food, housing, and case management. And when the researchers dug a little deeper and found out which enabling services were most requested, the most requested services were case management, housing, and transportation. So this should give you some ideas about services that are being used and needed and prioritized in your community, and help you think a little bit about the extent to which your programs are providing such services. But looking broadly at the framework and how we defined outreach activities, it included eligibility and enrollment work. So certainly all of the outreach and enrollment stuff that you all have been doing since the implementation of the Affordable Care Act. There's another resource there was a webinar yesterday that I would encourage you to listen to or read the issue brief. The Kaiser Family Foundation did a series of, well, the Healthcare for the Homeless Council and others did a series of focus groups on behalf of the Kaiser Family Foundation and found out what's going on now after the first open enrollment and post-open enrollment period in Medicaid expansion states versus non-expansion states. And a lot of really poignant things came out of increasing insurance coverage for individuals experiencing homelessness. Things like people now having access to needed surgeries and access to prescriptions that they might have had to rely on those medications that were available through prescription assistance programs or through samples that the health centers might have. Access in some cases to dental health and vision services that they never had access to before. So lots of important things for the folks in the Medicaid expansion states are happening as a result of your very important eligibility and enrollment activities. Another key function of outreach is patient recruitment and awareness of health center services. So being out in the community, and this certainly doesn't require a clinician, right? A lot of these do not. But there is such value to being in the community regularly, consistently, building relationships, building trust, and over time making people aware of what you've got and how they can get access to it, whether it's coming into your health center or getting health care on a mobile health unit that you've set up or using other services that you have available in the community. Transportation is another activity that a lot of programs provide. Lots of programs will either bring people into the health center for services, take people to specialty care, in some cases provide vouchers or bus tokens, but somehow arranging for transportation is often an activity of outreach programs, in addition to an input that I talked about, a cost that you have to consider. Interpretation for your patients who have limited English proficiency is very important, both speaking and written translation of written materials. And interpretation is often provided by outreach staff. Case management and care coordination are huge, and especially for the Healthcare for the Homeless programs. We've heard over and over that your patients have multiple complex needs and really need a lot of help addressing those needs, navigating their way through the system. So case management and care coordination is very important. The costing tool that was described in the webinar yesterday showed really impressive financial benefits specifically for case management and showed how to make a case for hospital systems and other community providers to support case management services in health centers. Health education is an activity that outreach workers, promotores, community health workers often engage in. Health education can be especially effective and timely in an outreach setting, in a community setting. And I've heard from many of the Healthcare for the Homeless programs that using peer educators can be an especially effective way of doing this. So making sure that peer educators who have been where the consumers are and can really speak to their specific issues and barriers and stressors in a really concrete way can be a good way to increase your health education. Medical services outside the clinic, I think you all know better than anyone that this is very important for being able to fully serve patients who have multiple complex needs and might have a really hard time for a number of reasons getting to services in a health center setting. community relationships is an activity that a lot of outreach programs engage in, and it really helps to make sure, because your health centers can't possibly address all of the needs of your patients, building good community relationships, building referral relationships, having partnerships with your homeless shelters, food banks, hospitals, schools, those can go really far toward enhancing the effectiveness and the value of your services. And then under outreach activities, you really need to make sure, if you're going to engage in any or all of these activities, that this dimension of integration, you have to take into account integrating outreach with the clinical and administrative priorities of the health center, having that good ongoing communication, make sure you're always doing evaluation so that you're not spending time in areas that aren't yielding good results, and having that good infrastructure, the program plan, the job descriptions, the protocols. These are all a very important piece of the activities. Okay, now we're going to look at outputs. So these are, again, the potential results of the work that you're doing. There's not a one-to-one correspondence. So if you're looking at the whole framework, and you will be able to have access to the whole framework, which I'll explain to you at the end. Eligibility and enrollment doesn't necessarily only yield new insured patients. It might also yield increased knowledge about the health center, increased trust with the health center. So there are a lot of different ways these outputs can be achieved through the activities that you engage in. But certainly eligibility and enrollment hopefully will yield lots of newly insured patients for you, whether they're existing patients who were converted from uninsured to insured, or people who were in your community and weren't patients of your program before but got insured and became patients at the same time. You'll almost certainly get new uninsured. You will certainly get new uninsured patients as well as a result of the outreach activities that you engage in. Especially in the non-expansion states, there are going to be lots of people who learn about you for the first time through outreach, who will then be able to be connected to you as a usual source of care. But this can help you meet grant requirements and requirements to other funders who are funding you to serve the most underserved in your communities. Appropriate utilization of primary care and inpatient care, hospital care, and especially emergency department care are really important potential results or potential outputs of outreach activities. Many Healthcare for the Homeless programs report that when they survey their patients on who has a usual source of care, many people report that they don't have a usual source of care, and many others report that the hospital emergency department is the first place they go when they have an illness. So if you have that outreach in the community where you're establishing a consistent, trusted presence, you're providing good health education, you're providing good information about the health center, you can really help people understand what primary preventive care is, and that even though you know their most important focus is on survival, you can help them hopefully access health services in a way that isn't burdensome for them and adding more to their list of very important things they need to do to take care of themselves. If you're doing these things, you will certainly increase the quality of care that people experience and their satisfaction. If people are getting a range of their needs met through direct service or referrals by the health centers that are serving them, it's going to increase the quality of the care that they get and how they feel about the care. Obviously, increased awareness of your services, whether it's through your eligibility outreach or general community-based outreach, relationship building, health education. You're going to create this awareness, again, be that trusting presence, and create some brand recognition. And this is very important for health centers in post-ACA era. We know that you have to make the shift from being what some people see as the provider of last resort to the provider of choice in your communities, and outreach can really help you become that provider of choice. Definitely requires integration, again, with the health center leadership and with clinical staff in order to have these desired outputs. Okay, now we're going to move to the potential financial benefits. And I know I sound like a broken record, but again, not all of these will apply to every program. You really have to consider your specific policy environment, payer arrangements, community needs, and programmatic capacity. So the first potential financial benefit is around increased patient revenue and grant funding. Certainly the eligibility assistance, the outreach and enrollment stuff, you're going to get increased visits from insured patients. But through your outreach, you'll also get increased visits from uninsured patients, which, as I mentioned, can help you meet the requirements and mandates of your 330 grant funding as well as other grant funding. But outreach can also increase patient retention. And retaining a patient is a lot less costly than getting a new patient. So outreach can really help with the patient retention piece. And again, that speaks to you becoming a provider of choice in your communities. When we did the key informant interviews with health center decision makers around the country, we captured some key comments that they had. They were telling us what they thought would be important to measure regarding outreach, regarding financial benefits, and they told us key things that they felt was important about outreach. So this health center COO said that outreach helps us right-size demand with capacity. When you have clinical capacity that is underutilized, outreach is worth the investment. This kind of approach, this kind of thinking, especially works well if you have a new access point, if you're a new start health center, or if you are seeing declining patient numbers, declining user numbers in your programs. That's where outreach can really help make sure that the capacity you have is being matched by the demand and not underutilized. Another person spoke of the patient retention piece, saying that outreach patients, often patients connect strongly to our outreach workers. They are a key part of patient retention. The second potential financial benefit is improved clinical efficiency. So this really speaks to how outreach can be used so that your providers can be working at the top of their license, so that your physicians, your nurses, nurse practitioners, physician assistants can be working at the top of their license, providing the clinical services that your folks need, and using outreach staff, support staff to do things that fit their skill sets. A couple of things that can help improve clinical efficiency include decreasing the no-show rates. That can happen by folks being out in the community providing a lot of education around the importance of keeping an appointment or canceling if they can't show up. I know a lot of your programs go around to different community sites and they just have walk-on services, and that's excellent. You don't have to worry about a lot of no-show rates if people can just access care at the time and place that's most convenient for them. But that education about the importance of keeping appointments can be very valuable if you also have an issue in your health center settings about no-show rates. Using voice mailbox services that a lot of health centers have set up for homeless patients. Sending reminder calls or texts if your folks have a phone. Many do not, and so in that case it really involves that one-on-one in-person assistance and education. And then again, as I said, expanding provider reach and capability to optimally care for their license. So you want to think about to optimally care for patients. You want to think about what kinds of things non-clinical staff can do that clinical staff might currently be doing. Is nutrition education something that you feel you could appropriately train folks to do? Is medication management something you could appropriately train folks to do? These are things that can save time for providers so that they can spend that time seeing more patients. This next quote speaks to something I'm going to talk about in a moment, but this really speaks to the triple aim potential financial benefits of addressing triple aim initiatives. So this CEO said, "We just implemented an alternative payment model where we're paid for care for a population rather than on visits. This allows us to utilize the whole team. In some cases, an outreach worker could meet the needs of the patient, precluding a visit. In this population management approach, the outreach worker becomes even more important." So this potential financial benefit, and there's an associated calculator, recognizes that health plans and Medicaid are increasingly using shared savings and pay-for-performance incentives, as well as patient-centered medical home or patient-centered health home supplemental payments to promote and reward primary care health homes in achieving the triple aim outcomes. And by the triple aim outcomes, I'm referring to improving patient experience, improving population health, and reducing per capita total health care costs. And by the way, the costing tool that was introduced in the webinar last week does a great job of showing how certain programs can reduce per capita total health care costs. So that's something you might consider looking into. What we're talking about here is really how can we look at cost reduction or financial gain for our specific programs and health centers. And then the fourth, this quote goes back to increased clinical efficiency. Transportation is an expense, but it's more expensive if the patient doesn't show up. So we looked at transportation as an input, as a resource, as a cost. We also looked at transportation as an activity. It can be very resource intensive, but it can do a lot of decrease of those no-show rates. So one of our interviewees felt that it was absolutely worth the expense. And then this again speaks to the triple aim potential financial benefits as well as clinical efficiency. The CEO said, "We're interested in how we extend the reach of our medical staff using outreach. We want to effectively manage our panel of patients with the optimal combination of staff, and the outreach worker can be part of that team." We've long advocated for having outreach staff, community health workers, those folks on the care team in a patient-centered medical home model, because these are people who know people's lives and realities the best. So I think this speaks really poignantly to that. The fourth and final big picture potential financial benefit is more about avoided costs than income, but it's leveraging community resources to avoid costs. So it includes establishing more and better referral relationships, attracting community partners who may give donations, in-kind donations or actual monetary donations, who may be able to help you go for different grants, who may provide volunteer time. Avoiding traditional marketing costs is huge. If your health center is spending a lot of money on radio ads or TV ads or print marketing, is there something that outreach folks could do face-to-face, one-on-one in the community that can decrease some of those costs? Community needs assessments are another area where outreach can be very valuable. And I think this report that I mentioned to you a little while ago is a perfect example of that. These were actually consumers in a lot of cases being well-trained and conducting interviews with other consumers in the field, and you got a lot of amazing needs data from that method. So if you're paying someone tens of thousands of dollars to do your health center needs assessments, could you save a little bit of that money and have outreach staff and or consumers do some of that instead and get frankly, more meaningful data in a lot of areas. And finally, providing cultural competency trainings. And we see this as both a way to reduce cost, because a lot of your outreach folks have a really good finger on the pulse of the needs of your client population and can do a great job of providing a lot of cultural competency trainings to your staff and potentially to staff in programs outside of your health center, making it a possible income generator for you if they could do 1 or 2 cultural competency trainings to other community-based organizations each year. This is a quote going back to the marketing. We've made a strategic decision that return on investment for outreach is greater for us than the return on investment for standard marketing, such as radio or TV. Another quote, one benefit is employee education in cultural competency. We didn't expect that. The outreach staff is able to train other staff in how to best deal with some of our patients, as well as helping other departments to deliver health messages. They become a proofreader as to what messages our patients can really understand. So we are now going to just talk about these key internal and external factors. So as you're considering which of these 4 potential financial benefits might make sense for you, there are key things to consider. For the outreach and enrollment calculator, for the increased patient revenue and grant funding potential financial benefit, you have to think about, are there new clients for your health center? Does your health center have an expansion agenda? If we did get more patients, could we accommodate them? And what are the payer sources for these new patients? The calculator will estimate the potential financial benefit for recruiting and enrolling new patients and converting existing patients. And it looks at potential revenue and also the level of effort by outreach staff and the costs per year of those staff to come up with an ultimate return on investment. If you're interested in the potential financial benefit of clinical efficiency, you have to think about what barriers could be addressed by outreach, how is information being shared between the outreach program and clinical staff, or how could it be shared? And are your clinical staff already operating at the top of their license, or are there things that outreach workers could contribute to? And the calculator looks at the financial benefit associated with improving the efficiency of your team by including an outreach worker on the care team. If you're interested in the financial benefits of alternative payment methodologies and including an outreach worker on care teams, you need to think about, do you even have a payment arrangement that rewards or funds processes or outcomes that outreach folks could help achieve? And think about how outreach is currently integrated with the clinical team or how you'd be willing to integrate it. So this calculator helps you figure out how much you might be able to expect in terms of return on investment for supplemental patient-centered health home payments or patient-centered medical home payments, pay-for-performance initiatives, and total cost of care, such as in an accountable care organization. Finally, the avoided cost calculator, the leveraging community resources. If you want to think about that type of financial benefit for your program, some key things to think about. Do you currently budget for marketing? Do you currently pay for community data that could be gathered by outreach workers? And are there other organizations that would benefit from your own outreach staff's expertise and knowledge? And that calculator looks at where you could avoid costs in those key areas. Molly, could you please go to slide 13 on my presentation? I'm done walking through the framework. And I want to wrap up my portion by telling you how you can access these tools and use them yourselves, and then we'll do some Q&A. So we have the dimensions of integration, which I showed you, and the strategic framework, which I've been walking through with you, available in a toolkit that's available to all of the health center program grantees. So your health centers and primary care associations, at least through the end of the year. They'll be available after the end of the year, but we'll will probably broaden that availability. So if you access it sooner rather than later, if you're interested, you might also be able to access assistance a little bit sooner. It's very easy to get to. I'm going to show you how to find it on our website. So I'm going to share my computer screen for just a moment and show you what this looks like. You would go to our main website page. It's either web.outreachpartners.org or www.outreachpartners.org. And on the very front page, you'll see this Outreach Business Value Framework and Toolkit are now available. At the bottom of this paragraph that describes the whole project, which I've just done for you, click here. And then it'll take you to a screen and explain that you can submit a request for access. It'll have you agree to the terms of use and a privacy policy. And then once your organization's information is received and we verify that you're with a health center and that you've agreed to the terms of use and privacy policy, we'll send you a workbook that will help you work through all of these different considerations, and you'll be able to submit data which we can run through the calculators and then give you back a customized report. So you'll get the workbook, you'll get the dimensions of integration and the strategic framework, and we will gladly crunch your numbers through the calculators and give you back a report. And also along the way, we'll be building a database of data that we can ultimately share with the broader health center community to talk about how programs are using and providing enabling services. Okay, so I'm going to stop sharing my screen and give it back to Molly, and we can go into the question and answer portion.
Thank you, Kristen. That was great. I will now begin the Q&A session. And the first question asks if we could show the outreach definition again. And if you don't mind, I'll just go back to that slide. And Kristen,
Sure.
If you want to expand on that at all, please feel free.
Again, it's very broad. It's very holistic. It includes a lot of what we typically talk about as enabling services, but includes facilitating access, doing health education, bringing healthcare directly to the community, helping people become equal partners in their health, and then the advocacy piece of increasing the community's awareness of the presence of individuals experiencing homelessness and other underserved populations. Molly,
Okay,
back to you.
Great. Thanks. The next question is, how does increased visits from uninsured patients increase revenue or grant funding?
So most of you on the call, I assume, are HRSA grantees. The Health Resources and Services Administration issues grants to health centers serving general underserved populations as well as special populations, including individuals experiencing homelessness. And to get a HRSA grant, you have to promise to serve a certain number of patients in your community. And if you're not doing that, they're getting a lot more circumspect about this, and they probably will not fund you again at the same level if you're not meeting your targets. And so you can't just be serving people for whom you can bill insurance. There's lots of need in your community. You tell HRSA what proportion of uninsured patients you have, what proportion you anticipate serving. I don't believe you need to hit a certain target of uninsured, but you certainly need to hit a certain target of overall patients, and especially if you're in a Medicaid non-expansion state, in order to hit those targets, in order to keep that revenue, you're going to need to keep serving lots of patients who are uninsured. Molly, back to you.
Thank you, Kristen. The next question is, does the framework apply to FQHCs who are not healthcare for the homeless designated? And is there a viable model for them to do this type of outreach?
The framework absolutely applies to grantees that are not necessarily healthcare for the homeless programs. we actually developed it with a view to have it apply to health centers serving a variety of underserved populations, including people experiencing homelessness. And the National Healthcare for the Homeless Council was really instrumental in helping us develop a few years back a set of national outreach guidelines for underserved populations. And a lot of this framework was built around that, as well as built around our 40-plus years of experience supporting health centers and doing outreach. But absolutely, health center programs that don't necessarily serve homeless patients can use this framework very effectively. Molly, are there other questions?
Yes, thanks, Kristen. The next question is, does the calculator incorporate avoided costs of care at higher cost settings or at higher acuity levels through projected impacts of preventative care provided through outreach? And if so, how?
Can you read that to me one more time? I think I know how to answer this question, but I'd like to hear the question again.
Okay. Does the calculator incorporate avoided costs of care at higher cost settings or at higher acuity levels through projected impact of preventative care provided through outreach? And if so, how?
Okay. I think the short answer is maybe. I think yes. The thing about the calculators, and this was, I was really wanting to think about the similarities and differences between these tools and the costing tool that you introduced last week. And one difference is these calculators ask the people using them to input all of their own data. So no assumptions are made that you do not input. So you input number of contacts you expect to be made, the total cost of care for different kinds of patients. You can be as aggressive or conservative as you want in inputting those numbers, but you would really use what you know about your programs and your cost of care in order to get the estimates. So because it isn't based on any assumptions other than the assumptions that you input, I think all of those things could be incorporated. Molly, do you think that answered the question?
I think it does for now. We have a few other questions, so and we're almost over, but I can get further clarification from the individuals who submitted it, and we can talk offline if we need to. But we do only have a few minutes left, so I'm going to try to fit in as many questions as possible. What role, if any, does EMS have in this? For example, if they're mobile and have quite a bit of medical knowledge or familiar with local providers.
EMS,
I guess emergency.
Well, this is, I mean, the idea behind this framework is that it can help you see the benefit of developing an integrated community health outreach program within your own health center setting. Certainly, EMS services can be vital, valid, very cost-effective. It may not have an impact on how you decide to fund your program. So I don't know if you would use these tools to evaluate the benefits of that, but it certainly acknowledges, I mean, I would absolutely acknowledge the value and benefit of those services. And in fact, that could be a really good community resource that is leveraged, that can be leveraged through your outreach program. So perhaps the avoided costs calculator actually would help you look specifically at that. Molly, next question.
Well, we have 1 minute left, so I'm going to go ahead and wrap up. Someone did ask for the Health Outreach Partners website, and I put that in the Q&A section, so you all should have the link to it. Also, the slides will be available, and you can get to that later. So thank you, Kristen, again, for your excellent presentation, and this will conclude our Q&A session. Thank you all for joining the webinar, Meeting the Health Center's Mission and Margin, Making the Business Case for Integrated Community Health Outreach Programs, produced by the National Healthcare for the Homeless Council. This webinar will be archived in 3 business days, and a link to the archived webinar will be emailed once it is available. Also, we can send the questions that were not asked to Kristen and ask her to respond to them, and we will also post them where the archived webinar is. At the close of this webinar, you will receive a survey link to evaluate the presentation. Please complete that survey so we are able to improve your webinar experience. Finally, we invite you to visit the National Healthcare for the Homeless Council website for a full listing of upcoming and archived council webinars as well as other educational opportunities. This meeting will now be closed.